jump in. Awesome. Hi, everyone. If you haven't been to office hours before, my name is Abigail Fisher, and I use she, her pronouns. I am a experienced designer, human-centered designer at the BHA, focused on provider technology. And I am typically your host for BHA Technology Office Hours. What are BHA Technology Office Hours? Office hours are meetings hosted by the BHA Tech team for behavioral health providers, typically for data admin staff, to receive consistent updates on changes and improvements to BHA managed tech systems, to surface and discuss technology related questions with the BHA Tech team, to provide feedback and expertise on ongoing tech efforts, and to understand opportunities that you have as providers to further engage with the BHA Tech team. All of past office hours slides, as well as recordings, can be found on the For Providers BHA webpage. And Sammy, if you could drop that link, that would be awesome. A couple of housekeeping items that we always go over. We have a survey for hot topics. One person submitted a hot topic on the BHC&E project. Unfortunately, Dan, who was our resident expert on BHC&E, is out sick. So I will be following up on those project updates via email. But if you ever have a topic that you want to discuss, you can update it in that survey. And Sammy, if you could drop that link in the chat, that would be awesome. Also, if you have topics in mind that you want us to discuss today during our Q&A section, please drop them in chat and we will follow up once we get through our agenda items. Like I said before, we have the BHA provider website as our source of truth for all of the agendas, slides, and recordings and Zoom meeting registrations for this meeting. And of course, you can always email our support desk with any questions you might have around technology related issues at any time. Something new that I want to promote this office hours is a sign-up sheet to stay informed. We're going to be sunsetting the Google group that manages this at the end of 2023 in using a new mailing option. So please, if you're already on the Google group, you don't have to do anything. But if you're not on the Google group and want to get BHA tech updates from us, please sign up at that sign up form. And Sammy will put that in the chat for me as well. So today we have a couple of topics to go through before our general Q&A. First of all, at the last office hours, y'all had the really awesome piece of feedback that you wanted to hear more from the BHA programs team. So we're joined by Paul Barnett, who is going to take us through a BHA programs 101. Then we're going to go through some quick slides on training schedules for the rest of the year on our different tech systems. Oh, did I freeze? Okay, I'm back. And then I think a lot of folks are on the call today to hear a little bit about the administrative burden CCAR DACOD's modernization share out, as well as a mini update on the referrals platform. And after that, we will go into open discussion and Q&A on any of the topics that you want us to go through that you're putting in chat. Let me just make sure I'm seeing the chat now about Heather. Heather should be admitted now, Joseph. All right, so let's get into it. I'm going to hand it over to Paul to take us through some 101 items on BHA programs.
Thank you. Hi, everyone. Thank you. My name is Paul Barnett. I'm the Director of Child, Youth, and Family Services here at the BHA. My pronouns are he, him. Glad to be in this group. So I'm just going to cover some of the basics of BHA programs and then add a few specifics, as well as talk about the BOSSOs that will be coming up in the near future. So what is a BHA program? It's a good question. The majority of the programs that the BHA runs are to ensure behavioral health services can be accessed by uninsured people. They create capacity for quality programs in behavioral health that are not covered by Medicaid. Medicaid is covered by another state agency, the Department of Healthcare Policy and Financing. Individuals can access BHA programs as clinically indicated, such as at community mental health centers, jail-based services, and others. These programs help co-create a people-first behavioral health system that meets the needs of all people in Colorado. Next slide. So this slide covers the program financing and payment, I'd say from a high level view. So we currently have over 300 contracts annually to operate the programs that we currently have. Most of those have been competitively procured based on state procurement laws, except in some cases, for example, for some smaller contracts, we can use some easier ways to get things into place. And the majority of our contracts are really covered by the three areas listed in this table. So the first is mental health services, and that is at the community mental health centers. In that statute and in those contracts, there are 5 required services that they have to provide within their communities and their service areas. Those are emergency services, inpatient, outpatient, partial hospitalization, and education and consultation services. I'll say that statute is fairly old, so some of those terms may not immediately be clear to you what they are. But for example, first episode psychosis is under partial hospitalization. So we contract with all of the designated community mental health centers in Colorado, and we fund quite a variety of services. Again, anything that is not covered by Medicaid. In some cases, we sort of augment Medicaid coverage for services that are maybe not reimbursed as highly, such as supported employment, for example. And I want to add that it's not just mental health services at the CMHCs, but of course they provide a number of substance use disorder services as well. Second row there is crisis services. So we have the administrative services organizations in Colorado, and they were developed to help provide and contract for crisis services in the state. And we just call those crisis service organizations. Now they're ASOs. And the crisis services include crisis stabilization units, mobile crisis respite, and walk-in centers. And I'll just add to that, the other crisis services that some of you may be familiar with is the crisis line or the hotline. They also have a warm line. That's not actually contracted through the ASOs, even though it's part of Colorado Crisis Services. It's actually contracted separately. So that's why we have over 300 contracts. Some of them are with separate providers. The ASOs also contract with us for a number of other services, such as CYMHTA, if you're familiar with that, and several others like that. We also have crisis resolution teams that are within crisis services, and that's somewhat new and still sort of being expanded and improved there. And then the third group there is substance use disorder services. So those are contracted through the managed services organizations. Again, they're covered statewide, and they offer a wide variety of SUD services. And specifically, most of those are contracted based on their ASAM levels, and they're licensed. Most of those providers are licensed through the BHA as ASAM providers. Next slide. So currently, this box the top box shows the BHA, and we contract with CMHCs directly, and then with the ASOs and MSOs. And then in the case of the ASOs and MSOs, they contract or subcontract then with a lot of direct service providers. In addition to this, there's several other agencies that we contract with directly, smaller groups generally. That's not listed here, but that's where we come up with over 300. All right, next slide. So how can you participate as a provider with the BHA. So we have the ones I just mentioned, the ASOs, MSOs, and the CMHCs. And this shows that the ASOs cover a couple of other programs that I mentioned. We also contract with a few of those same agencies that either function as an ASO or an MSO, such as a Signal Behavioral Health Network. We have a separate contract with them for iMatter. And we have some other kind of special arrangements like that to get certain programs off the ground that come to us through legislation. Next slide. And thank you, Mark Conajani, for adding a couple of slides here. This shows the regions for MSOs, and it shows the MSOs that we contract with. Signal, I just mentioned, they have those 4 regions, Diversis and Rocky Mountain Health Plans. Next slide. And these are the ASO regions. Again, Signal functions as both of those. So they have 3 of the regions. Carolina has 2, and then Health Colorado and Rocky Mountain Health Plans. And I don't think we have a map in this slideshow for the CMHCs, but there's a whole separate map for the CMHCs and their coverage areas. Okay, next slide. I mentioned the BOSOs, that's what we're calling it. That's Behavioral Health Administrative Services Organizations. And the idea will be we'll have one contract from the BHA to 1 or more BOSOs, and then they will then subcontract with probably many of the same providers we have now, mental health centers, substance use disorder treatment, crisis services, and many of the others. So there will be one state map that covers the different regions that the BOSOs cover. We believe that will provide greater integration across the system for all of these behavioral health services, and we'll be contracting with one company regionally to provide all of our services. Should also decrease provider burden and make it easier for Coloradans to navigate the system and get connected to the care that they need. Okay, I think that's it for me. And we want, do we want to take any questions at this point? I see one in the chat there.
Yeah, and Elizabeth also has her hand open. I think you use she, her pronouns, Elizabeth. But maybe that's the same question you put in the chat. So just so everybody can hear, Elizabeth said, Paul, are you saying there will only be one BOSO?
No. I don't know how many there will be. I think there will be one. There will be one or more. There have been different ideas about how many. I don't know how many there will be at this point.
Okay, thank you.
Any other questions?
Awesome.
Thanks, everyone.
And so what I'll do is, oh, Paige has a question. Won't it be like the raise where CMHC providers will have to contract with all of the BOSOs?
That's a good question. I would think so. I work specifically with the child, youth, and family team. I'm not on the senior leadership team. I would say that's a question that senior leadership would be able to answer better. I mean, that's sort of how I conceptualize it, but I'm not super involved in that. So I hope that's a reasonable answer, but that's probably the best I can give you at this point.
I can hop in real quick too. This is Kristen Lara. So I can't remember, Paul, if in the slide deck you just showed there was that diagram of the difference between now and when we have the BOSOs. I feel like you did show that. I don't know if we can pop that back up. I kind of
did not have the future state. We had current, but we just talked about the future state. We didn't have that other slide that you're probably thinking about.
So generally the intention from the legislation that created the BOSOs is to streamline contracting processes for CMHCs, ASOs, and MSOs to one singular contract mechanism. I might be careful with the comparison to the rays just because the rays do serve a different function than the BHAs. There are similarities and differences. So I think it might be clearer to say that yes, the BHA will have contracts with the BHAs that cover services, including many of the functions that currently CMHCs perform, as well as services that we contract out through ASOs and MSOs. And then a reminder that the request for information is currently open and out, and many of these questions are questions that we would love input from people in Colorado on to help us shape this together for release in the request for proposals sometime in the spring. So please do take a peek at that if that is not something that you've already had the opportunity to go through. We've put a lot of information out on the what we do know currently related to the BHAs and where we need additional feedback in order to shape that request for proposals. And I will drop in, if someone didn't already, I will drop in some information in the chat in a moment on how to get to the request for information and additional like written information or summary from the BHA on the BHAs.
Great. And then Paige had another question, and I'm not sure if we covered this off yet, but Paige said, since there's no membership or eligibility for these programs, maybe there won't be a reason to contract with our non-home BHAs.
Paige, can you go to voice on that one? And it may or may not be something that I'm able to answer. So because this is a competitive procurement process, we're really limited to the information that we've released related to that request for information, just to make sure everybody has access to the same things. And so if it's something that we've already made a decision on and specified within that forum, then we can talk through it here. If not, it might be something that we asked for additional information on. So Paige, are you able to go to voice on that question?
I am, if you can hear me. Yeah, it's just a question of, trying to differentiate between what the Rays are doing in the BHAs, even though now the regions are going to look the same. Instead of us contracting primarily with the state, do we end up with more contracts? Just because with these programs, we are not, unlike the Rays, we're not managing, it's not a managed care plan where you have members and there's eligibility of whether they're in the plan or out. If we're looking at, quote, to use the old term, indigent, there's some eligibility, but it's done almost at the service CCAR type of a level, not a plan. So, things I've seen on Peak Pro, you can check people's eligibility for these programs, which seems kind of strange because it's not the same kind of eligibility as being eligible for Medicaid. So if, say, for our CMHC contract, if we're only serving our, quote, home counties, if somebody lives somewhere in the West Slope and is coming to southeastern Colorado, is there an issue with their home address or anything, and versus where they're getting services and which BHASA is going to pay for services on which, or is it more the BHASA is funding the services of a CMHC regardless of where the clients are coming from, which is essentially how it is now.
So big picture, I will say that we intend for the money to follow the provider, not the person. And in that meaning, we fund providers. You're correct that the BHA doesn't have members. So in that way, the Rays and the BHASas will function differently. Within the Rays have individual people who are Medicaid members that are assigned or associated to that Ray. We do not have currently, and will continue to not have like individual BHA members because we do not run an entitlement program, and instead are providing funds to providers through the BHASas to provide safety net services. That answer your question, Paige?
I think it does, but then it also brings up a question is I've got some staff going through Peak Pro training, and it says CMHCs should get involved in this because you can check eligibility for BHA programs, which didn't make a lot of sense. So I'm curious, and I know it's not on the list today, but if there's a quick answer to what is Peak Pro going to be used for in this realm?
Yes, that's a great question. So Peak Pro and Peak can be used the same way, and whether you use Peak or Peak Pro is really a workflow decision on your part. So we know that you currently use that to assess and help with people who don't already have or haven't recently checked whether or not they're eligible for Medicaid to get them enrolled into Medicaid. We are aligning that process across Medicaid or HCPF and BHA. The enrollment process within Peak for BHA funded services or BHA community services is a very limited subset of pieces of information that are also a part of the Medicaid application. I don't have the list in my hot little hands, but I feel like it's something like 5 to 10 criteria, not many pieces of information that are collected for a full Medicaid application. In a perfect world, you're helping someone to identify and initiate enrollment into Medicaid. And then if they are denied that, they could get enrolled or signed up via Peak or Peak Pro into BHA community services. That helps us at the state level be able to do a couple of things. One, it helps us to ensure that where people are eligible for Medicaid, we're using Medicaid first. And that helps us be able to spread and stretch our BHA dollars further. And it ultimately brings more money into the state of Colorado to support behavioral health services. So that is one of the core goals from a workflow perspective, is to understand when we're successfully able to enroll people onto Medicaid, where that's not realistic, feasible, possible, where people aren't eligible. And then it also helps us to coordinate and monitor services for individuals who need both Medicaid and BHA funded services, and then funded BHA services alone. So it's enabling some of that overarching tracking, monitoring, and alignment between the way that HCPF manages, the way that they collect information and manage their Medicaid dollars, and how we do that for BHA funded services. Did that help? I think part of your question might be, I don't know if this is part of your question, but you're not going to see in Peak or Peak Pro additional information on the individual services or programs that are offered or managed through the BHA. It's a blanket, essentially eligible or not eligible. There are two different criteria or groupings within that BHA community services enrollment. One indicates that they are means tested, so I think it's at or under 300% of the federal poverty level, and the other is a catch-all that essentially anyone in the state of Colorado would apply for or qualify for. These are also reasons why we want to make sure that enrollment process, for the most part, gets initiated by BHA contracted providers, because CMHCs, as an example, are a primary conduit or mechanism for individuals to understand and access BHA funded services.
Okay, and besides the 300%, I know there's basically, call it an SPMI diagnosis criteria, which is the other big one, which I'm not sure how that would work through a Peak Pro system. So I hear what you're saying, but as I'm thinking through the specifics, it's still fuzzy for me. It almost seems like if you're not Medicaid eligible, it's a general referral to BHA services, but not anything specific. It doesn't say, oh, you're in this area, therefore this is the closest provider. Here's their contact information for this kind of a program, or
I think that is correct. And to be honest, I think that our hope is this is primarily initiated by BHA contracted providers. So you're with somebody that you're providing support or services to, and you've identified someone who you think would benefit from some program or support that's available through the BHA. And on the flip side, if they're learning about it through Peak in general or through a county human services office, they should be pointing them back again to the most likely to the mental health center that's in their community.
Which sounds a little bit like maybe what care coordination under the BHA might look like, because it won't be what the Rays do.
Potentially. We'd have to go into that in more detail. I bet we don't have time for that today, but
Okay.
I do hope these are all very good questions. I hope this is helping us kind of figure out together how the rubber meets the road, both in terms of the behavioral health claims and eligibility project and how that relates in the current state to our current BHA programs. I also know that that could be really complex to process, what that looks like in current state, how we support and build capacity in this current state, with the understanding that the BOSSOs will exist come a year and a half or so.
Okay, thank you.
Yeah.
Absolutely.
Thank you so much, Paige and Kristen. So I have one more question from the chat, and I will also promise like the same thing that we did with BHA programs where we prepared the next month with more talking points. I'll do the same thing on this topic so we can dedicate more time to this in our November office hours. But I'm wondering, to cap us off, Kristen, Edie had a question that in the BOSSOs, the money will follow the provider, not the person. Is that correct?
Yes, that is correct.
Okay. All right. Thank you, Kristen and Paul. And thank you, everyone. Those are really excellent questions, and we'll come prepared next month to dedicate more time there. I'm going to transition us back to our other topics, because I know that I think a lot of folks on the call are here for some updates on administrative burden. So I want to make sure that we have ample time for those slides. All right, so very quickly, I'm going to share up, and this is also in chat, our training schedule on our technology platforms for the remainder of the year. I also want to preview that in 2023, we will have a different process for folks signing up for these training schedules. So towards the end of the year, we can provide more feedback on that. But here is the remaining training sessions for CCAR, DMS, and DRS and DACODs for the remainder of 2023. And again, this is also in chat, and I will share this and follow up with this information as well. And does anybody have any questions on trainings before I move us to admin burden? Okay. And you can put questions in chat, and can also bring up any questions you have during our Q&A at the end of today as well. All right. Admin burden, modernizing CCAR DACODs. So we are so excited. You may have actually already got an email from me or the BHA this morning. Really ecstatic to be able to share our final report and detail on how we will engage providers and gather and act on their feedback on that final report. So if you have been attending office hours, you may have been getting updates from us along the way, but from March through July of 2023, we dedicated a research effort to CCAR DACODs and the administrative burden that they cause from the BHA's positionality. Did a lot of research, engaged with 16 provider organizations across a variety of representational vectors, including geography, tech resourcing, and service provided. And we conducted hour-long interviews and several virtual site visits with that group, and talked with over 60 individuals from those provider organizations to come up with the report that we're happy to share with you today. If you go to the admin burden project site that I put in the chat, that is everything that you need to engage with this piece of work, including the full final report, a presentation of the findings, and ways to sign up for feedback sessions. So I will not be giving a full presentation of the findings today. Instead, I will be hosting 3 sessions next week, an hour and a half each, across different times and days, in order to spend 45 minutes going deep into the findings with folks from providers and other stakeholders, and then holding discussion for about 30 minutes in terms of those sessions. One of the things we want to make clear is that although there are many sources of administrative burden caused by the BHA and our contracts and processes, we want folks to know that we intentionally began with CCAR and DACODs because we understood from our research with providers that these are the most prevalent and negatively impactful reports on providers today. So rest assured, we will continue our investigation of administrative burden at the BHA in parallel with the implementation of the plan that's recorded in this report. So although I won't be going through the full kind of report recommendations and findings today, I will give you a sneak peek in terms of our key recommendations out of that report. And I'll also be going through how you can engage in those sessions, as well as in the community stakeholdering process that will be conducted over the next few weeks. So to begin, what were our top findings? And how did we balance those into recommendations for a path forward? So one of the first things we're going to consider with CCAR and DACODs is updating our data model through relevant stakeholdering with groups like this, as well as a federal review process, in order to put forward more culturally competent language around gender, race, and ethnicity, among other data terminology, for front-end presentation and integration into provider systems. Next, we need to select a data entry system. So we know that the systems that intake CCAR and DACODs today are really difficult to use, and don't have the functionality that we need in order to do data analysis that would be best to share back with all of you. So we will be performing an analysis of existing internal and external technology systems in order to understand what is the best path forward. And we will also be stakeholdering that decision for feedback with providers. Next, we're going to build the system and the data model for episodic reporting. So we're creating a reporting environment where we can start to collect and tie together longitudinal data. So we're not only seeing snapshots of clients, but instead their entire care history with the state. Next, we will be thinking about how we're going to share this data back to providers, creating standard and customizable data analysis dashboards so providers can better track their progress towards contractual requirements as well as measures of equity. And oh gosh, this is really causing. And 5, we're going to prioritize engagement. So you heard me talk through all of these about how we won't do anything that will impact providers without providers' feedback. So we will create a robust external communication and engagement plan, of which this initial share of the report is the beginning of that plan, to foster trust and transparency around this process. So again, just to hit this home, ultimately the success of this project hinges on accurate, transparent communication and engagement opportunities with providers like you all. So we know that we need to consider that. And the microsite or the project site that I included in the chat is where we will be keeping folks informed of all of the efforts around this initiative. A quick snapshot at our tentative timeline. So this timeline maps out our steps through the end of 2023 and into July of 2024. And you can see here that we will be kind of getting into a process of sharing an element of this plan, having moments for public feedback, resharing out the changes to the plan based on that feedback, before we move forward with any mandates in terms of changes to provider processes. So finally, what are our calls to action to you? We would love you to read the full report, watch a video of the presentations, or come to one of the sessions that we will be holding next week. All of those signups will be available on that site page, and I will also email them out to all of you. We have if you don't feel comfortable giving us feedback in one of those sessions, we have a feedback form that you can fill out anonymously. All feedback that we receive, either via voice in these sessions or submitted to the form, will be responded to publicly by the BHA so that we have parity of information across all of our providers. And then finally, sign up to get email updates. So we have your email. If you're curious and want to get periodic emails from us on this initiative, please fill out that update form that I put in chat, and we will make sure that you are staying informed about this initiative. And I see many chats, which I will get to in just a minute. This is the last slide on this initiative. So we will be collecting feedback via that form and via live sessions until October 27th. We're hoping that we can then respond publicly to that feedback by mid-November. And again, everything will be on that project site. And then the week after we respond to the feedback, we will host additional share out and discussion sessions, which are to be scheduled in order to engage in live feedback and discussion around thoughts from providers on the report. And likely at that session, we will also be presenting out additional ways to engage through things like working groups or feedback opportunities on things like the data model or the technology system selection. Okay, I see a bunch of chats. I'm going to read those now. These look like.
I think you're good. I think they're just
Okay.
my follow-up answer to Edie confirming, and then information on how to get to that request for information, and additional information on the bosses. That closes on November 3rd, so you guys still have a few weeks to read through that, ask questions, and provide feedback to the BHA.
Awesome. Thanks, Kristen. All right, so I'd love to pause and answer any and all questions about this. I think it would be particularly important about any questions related to like how the BHA is going to gather feedback, as I'll be better prepared and have more time to answer questions about the material of the report in those live feedback sessions next week, if that makes sense. But any questions at all, and we can go from there. Andrew, go for it.
Oops. So I'm Andy Rose, and I organize the Independent Provider Network. So we're concerned. We have an exemption from CCARs for 3 or 4 years now, and the report did not mention the IPN. We are not exempt from BHA licensure once our clinics get large, and we anticipate that there'll be further legislation to have more independent provider networks required to have BHA licensure. So this is half of outpatient care or more currently does not collect the CCAR data except for what's in the 1500 forms. So I guess I'm curious about the data collection and is the 1500 form sufficient for the goals that you have? Maybe you can say how that dynamic of the raised and HIPAA not requiring the CCAR informs the conversation. Thanks, Abigail.
Yeah, thank you, Andrew. I might have to tag in some additional folks on that question, because what this report focuses on is more of, for those who are currently submitting CCAR and DACODs, how the process can and will change. But what the report doesn't touch on, to your point, is, how changes to the BHA licensing will impact who submits. And so I might direct your question to more of the licensing team and the contracting team, just to make sure that I'm getting that right. And Kristen, I'm looking at you a little bit to make sure that those are the right folks to direct that question to.
Yes.
Okay.
Yes, I agree. And I think that this is a great example of something that we should dig into further over these coming weeks as part of these feedback sessions. So I appreciate you raising it. Totally agree with Abigail that the focus of this has been on current providers that are currently reporting these and how we reduce that administrative burden. And I think that your point is a good one. I think the general question from you, Andy, is as the BHA is changing who and how we regulate providers, what might be the impact of these types of requirements on new providers in that future state or future setting?
Cool. Thanks, Kristen. So Andrew, I will get back to you on that with an answer or for how we will engage on that question in the future with representation from that team. And I will also share that broadly with the entire email list for office hours. So thanks for your understanding there. Joseph, go for it.
Since they're talking about changing the day codes and changing the C cars, when can we expect the new specifications for the data elements that are going to be required in the answers and all the questions? And because it's going to require time for us to get our system changed and time for the providers to get their systems changed.
Yeah, absolutely, Joseph. Great question. So we've put a stake in the ground that we will give providers a full year upon release of those specifications to make those updates without any mandates tied to them. So this is what we can, this timeline is what we're able to estimate out at this time. And we will be able to release more detailed timelines the further we get into this project. But rest assured, we really understand the need for the time for providers to update their systems. And we're very much building that into this process. Is that a good enough answer for you?
Yeah, thank you. It's hard when you don't quite know where you're going to end up at.
Yes, correct. Exactly. And that's why we really, hinge this work on values of iterative product management and product design, because we don't want to overpromise and then deliver something differently. And we know that transparency and accuracy around timelines is incredibly important. So thank you for bringing that up. Great questions, y'all. Anything else that I can answer for you today? Yes. So Barrett, yes, there is plans to reduce the number of elements required by the CCAR DACODs. And you can read about that specifically within the data model recommendations section of the full report. So Joseph, it is interrelated to the work HMA is doing, but a separate initiative. So HMA is currently tasked with the universal contracting provisions, of which a new version of CCAR DACODs might be integrated into their work, but this is kind of its own work plan, if that makes sense.
And if it helps, Abigail, and again, we'll follow up on this later, but the universal contract provisions might be also the connection point for what Andrew Rose was asking about earlier.
Correct. That's exactly right. Cool beans. All right, well, we'll have more Q&A section at the end. So if you think of questions along the way, I'm just going to blast through this last section to get us there. So a quick update on the referrals platform. I also included a link to the project microsite in the chat as well for this initiative. So again, all of the relevant information you would ever need will be on that site for this project. If we look at the sort of timeline going into January of 2024, we're currently in the middle of October. So for folks that haven't been to office hours, we've conducted 2 user testing sessions already in an in-progress version of this platform, and we will conduct 1 more group before launch in January. So I have my email on the next slide, and if you want to be a test user of this platform, please send me a note and I will get you added. We will also be promising a more detailed launch timeline in November, so providers have ample time to prepare, back to Joseph's point. Providing a little bit more detail here, I think most folks know about this. We're currently conducting both research and user testing on the upcoming referrals platform in parallel. We will be sharing out findings from our second group of user test users shortly, again, on the Project microsite. We will also have a new research report detailing what providers will be able to expect from the platform in January in terms of features and functionalities. And we're hoping to be able to share that in November. And again, we'll have 1 more test user testing session in November. So please email me, and I'm hoping someone can drop my email in the chat if you want to be considered as a test user for the platform. And again, if you're not familiar with this project, I encourage you to read up on that microsite because it has all of the good information that we currently are able to share about this project. Any questions on referrals before I jump us to Q&A? All right. Then I'm going to stop sharing my screen. And so for folks that don't typically come to this meeting, we try to hold a good chunk of time for just any questions that providers might have for us. So totally open via chat or come off mute. Any questions for us on any topic? Go for it, Elizabeth.
Hi, Abigail. I know you said that Dan is not here today. Does that mean that you are not able to answer any questions related to BHC&E?
That's correct. I did get a question on the hot topic survey around BHC&E that I'm currently trying to get answers on, that I will email everybody on, but unfortunately, sort of the project experts on that are gone. But if you want to put any questions you have in the chat, I can follow up and get those to you asynchronously.
Sure, thanks, appreciate it.
Thanks, Elizabeth, sorry about that.
Oh, no worries. I mean, people get sick, they're allowed to be out.
That's very true. All right. Well, folks, what we typically do if we have a quieter crowd is all the BHA representatives will stay on this call until 2 p.m. If people want to mill around or just talk to us or ask questions, otherwise feel free to log off. And I hope to see a lot of y'all at our admin burden CCAR DACOD's modernization sessions next week, where we'll be getting into the guts of that content. And thank you for your participation as always. But yeah, we'll be here. We'll just be here chilling until 2.
Abigail, this is Werner. A question: you said we'll have a year to implement CCAR stakeholders. When does the year start on your timeline?
So we don't know yet. So
okay.
So we can estimate up to a certain extent, and if I can reshare that timeline again, like this is what we were able to estimate so far that we feel good about. And then, you know, we'll need to go a little bit further out until we're able to give you that exact date.
Yeah, because that seems to say we have 3 months implementation period between April and June. That's why I was confused about the year. What do you include in a year and what do you not include in a year?
So that implementation period is just if people want to work ahead. You know, and I think I'll talk about this in more depth at the presentation, so forgive me if my talking points are a little off. But the state needs a certain amount of time in order to prepare to make sure we're able to accept the new data model. And based on this timeline, in July is when we are planning to be able to accept that data model. So,
Okay.
so likely somewhere in, February or March, depending on how fast the federal review is, we'll be able to hand over those new data model specs. Okay, and I'm just going to stop talking because Justin has his hand up, so I'm going to let him speak to this.
Thanks, Abigail. Apologies if there's some background noise. The goal here is for us to be able to accept both current and new model in parallel for a year to give you the chance to implement it when you're ready. So
Okay,
our
that's-
goal is to say, you can give us either date where everyone on the same date.
No, I got it. Thank you. That helps. Yeah. So you basically you plan to have it maybe February, March, so we can start early if you want to, and then starting July, you're gonna accept the old or the new one for the next fiscal year. Basically, that's how I understand it at the moment. And it's clear that may get fine-tuned, but that's at least at the moment my understanding. Is it correct?
I think
Cool.
that is right from my perspective.
Perfect. Yeah.
Great
Thanks,
question.
Justin. Thanks, Abigail. Thanks, Justin.
Is the data model, and then I'm looking at the bottom where it says text system, I'm reading data model is whatever the text system will want to capture. So the data model is sort of the what and the text system is the how. And Werner's talking about implementing a new how, which will come way after the what.
So it depends. It depends on how your organization has it set up to enter CCAR and DACODs. So some providers, it's a hard question to ask, and I almost want to punt back to Justin on that. But we kind of talk about this as two tracks, right? Because there are two distinct tracks. We need to do work on the data model to update it, and that has nothing to do with what tech systems we're using. And then we have to decide what new tech system we want to be the entry front door for providers. And that will be more relevant to certain providers than others, because certain providers will, and Justin, keep me honest here, likely have more automated processes. Okay, I'm going to stop. So Justin takes over.
This is, again, a great question. And I think that what you're submitting and how you're submitting it is a really great framing. So you have a way to currently submit CCAR day codes. That will not change with the data model update, but what you submit through that process will update with the data model changes. As we then go into the tech system changes, that will open up opportunities for how you submit it. Is that through an automated process? Does it continue to be a batch process? Is it a web interface, etc.? So what you're submitting will change first, and then the how you're submitting it will change second. We're hoping that we will at least be able to give you an indication of both as early as possible so that you can plan at least directionally, if that makes sense.
Yes, and both will require internal system changes, reprogramming at the provider level.
Correct, which is why we will give that same grace period in terms of the technical system as well as the data model, because we know that those are, the two big efforts, and they'll be different depending on how large of an organization you are and also how your tech is set up.
Yeah, typically mental health centers implement it in the EHR and submit it in a batch process. That's what we are doing. So we are not going online on a portal and doing a CCAR. It's different for the day codes, but this is a smaller number.
So I will add that our goal here is to minimize the pain. In all the things that we're doing, our goal is to minimize the pain. And so that includes implementation time, cost, and effort. So part of the discovery will include things like what is currently happening and how do we do this in a way that doesn't cause undue burden on your technical team or your implementation folks. That is very much on our mind.
All right. right, is this a good spot for a ladders question? Yes, this is a perfect spot. Go for it.
Oh, good. This is Tamara.
Hi.
And I was wondering, we're getting ready to reapply for the BHE license that expires, I think it's January 31st.
Mhm.
So I'm hoping to get into ladders to do that. Is there some timelines that ladders is going to be ready for that?
Yes, Kristen, I saw you come off mute. Go
But
for
like
it.
there are, I don't know if we have a firm date. I think it kind of depends on when everything gets approved by the State Board of Human Services. Our hope, we're kind of anticipation, we're ready to release that, I believe, sometime in mid-November. To make sure that providers can pop in before January to start that process. I don't think we have exact dates, and I do think that additional training along with that is forthcoming from the quality and standards team at BHA.
Great. Thank you so much.
Absolutely.
Great questions, y'all. 2 minutes left. We probably have time for one more if anybody has anything. Thanks, Nicole. All right, folks. I'm going to let everybody go. Thank you so much for your time again, and feel free to reach out on all the channels if you have any questions, and we'll see you next month. Thank you so much. Bye.